Nivolumab versus Everolimus in advanced renal cell carcinoma. Definition: renal cell carcinoma is the most common form of kidney cancer with more than 330,000 cases diagnosed and more than 114,000 deaths attributed to it worldwide. Every year, approximately a third of patients present with metastatic disease. A diagnosis and in about one-third of the time, patients with localized disease, the disease will relapse. Continuing with the video.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Application in medicine. Nivolumab improved overall survival and objective response rate versus Everolimus in previously treated patients with advanced renal cell carcinoma in the phase 2. Research that nivolumab as compared with Everolimus prolonged survival among patients with previous treatment advanced renal cell carcinoma. Continue with the video.
For the most part, the mainstay of treatment for kidney cancer has been VEGF-targeted therapies with drugs like sunitinib and pazopanib. But recently, there's been breakthroughs with the approval of Nivolumab for advanced renal cell carcinoma. Now, Nivolumab was studied in a pivotal phase 3 trial and compared to Everolimus in patients who had progressed on drugs like sunitinib and pazopanib. The primary endpoint of the trial was overall survival, and the primary endpoint was reached, showing a benefit in overall survival for Nivolumab compared to Everolimus, and establishing it as a new standard of care in patients who had progressed on sunitinib or pazopanib. The other endpoints we looked at were response, and there was a higher response rate associated with Nivolumab compared to Everolimus. But what's most noteworthy is, in addition to the high response rate, many of the responses were durable, with the average or median duration of response of 12 months at the time of the data analysis, and many of the responses were continuing at that point. We also examined progression-free survival, and there wasn't an improvement in progression-free survival over Everolimus. I think there's probably a couple reasons for that. One is this phenomena of pseudoprogression, where sometimes the tumor actually gets a little larger. And the other is the mechanism of immunotherapy is different than that of VEGF-targeted therapies, and so some of the responses may be later, or some of the benefit may be in a group of patients who achieve a long-standing response rather than the majority benefit and by progression-free survival.
Pros and cons. Pros. An increase in the progression-free survival for the combination of nivolumab and ipilimumab has been established in comparison with nivolumab alone, only in patients with low PD-L1 expression in the tumor. Cons. Upper respiratory tract infection, disgrace, appetite, periperenal neuropathy, and headache, abdominal pain, constipation, dry mouth, hypertension.
We've seen in the CheckMate 025 phase 3 trial that nivolumab was superior to everolimus in patients who failed prior anti-angiogenic therapy, and with improvements in both overall survival, quality of life, and safety in that trial. But the follow-up on that trial was relatively short, a minimum of 14 months. So the question we tried to address by looking at the phase 1 and phase 2 trials is, with longer follow-up, what might we see in the phase 3 trial? A sort of a way of looking potentially into the future. Obviously, there's a question with these agents. They're given over a long period of time. What does toxicity look like when you give an immune therapy, for 2 years or more? And interestingly, just like the responses mainly happen early within the first 6 months, so does most of the toxicity. So if you look beyond 6 months on the phase 1 and 2 trials, the toxicity incidents seem to decrease. And out beyond 30 months on the phase 2 trial, we didn't see any treatment-related adverse events. So that's encouraging for patients who may need chronic therapy to remain in benefit, as they're not, at least on that trial, we're not accumulating significant side effects.
Issue of play in Ecuador. Kidney cancer were the seventh most common malignancy and accounting for 3.3% of all newly diagnosed cancer in Ecuador. Renal cell carcinoma constituye aproximadamente 19.95% of can-killing neoplasms, and 25 and 30% of all patients have metastatic disease upon of diagnosis. Conclusion. Among patients with previously treated advanced renal cell carcinoma, overall survival was longer and fewer grade 3 or 4 adverse events occurred with nivolumab than with everolimus. Thank you.